diagnose this early if we have to effect regression from advanced cirrhosis downwards to just steatohepatitis or fatty liver disease. Also equally important is the fact that we need to identify factors which tend to cause disease progression. These may be diabetes, insulin resistance, obesity, and we've had the previous lecture which spoke so highly about what obesity can do to people. And that's really a true reality that we need to do in our patients, a check that we need to see. Now, there could be various pathways for mast cell. This could be genetic, it could be just de novo lipogenesis in the liver, or these could be adipose tissue dysfunction. Importance is the fact that when people tend to have a genetic predisposition that tends to cause fatty liver disease, these patients usually present to us with steatohepatitis and cirrhosis. But when you have patients who develop fatty liver disease due to de novo lipogenesis or adipocyte dysfunction, then these patients invariably present to us with non-communicable diseases. They have insulin resistance, diabetes, cardiovascular risk. So there is a clear differentiation that you see now in the way that patients develop fatty liver disease and its correlation to how they will progress in future. All this while we have sort of associated fatty liver disease with obesity. But now we do recognize that we tend to have a segment within the normal BMI, and that is something that we talk about, normal weight obesity. So you have thin people, but they tend to be metabolic fat, and they tend to have ectopic fat in a higher amounts. So this is the concept of lean MASH that we tend to talk about. It's very similar to the obesity-induced MASH, but it's kind of a toned-down version of what we see. And these people usually will still present with all the problems that are associated with NAFLD and NASH, but probably in a lower scale as compared to what they would happen in patients who had obesity-induced NASH. And here's some differentiation points, but for want of time, I'm not going to get into how we can differentiate between lean MASH and non-lean MASH. But effectively, they're very similar in a toned-down version. Now, why did we really move from talking from NAFLD to MASLD? And why was this nomenclature really important for us? So the host of world bodies got together and said that, is really NAFLD a good terminology to use in our patients? Number one, it's not really always associated with alcoholism. And if you talk about alcoholic fatty liver disease, then it has a certain amount of stigma attached to it. Again, when you talk about fatty liver disease, there is some amount of stigma attached to the word fatty. And we don't really factor in the cardiometabolic risk factors that are associated with fatty liver disease. And that's why the shift from NAFLD to MASLD, and this is the new classification of steatotic liver disease that we've got. So on one end of the spectrum, we've got MASLD leading to MASH. Then we've got a combination of alcohol and metabolic dysfunction, so that we call as MET-ALD. And based on the factor of how much of alcoholism the patient has got, so it can be alcohol predominant or metabolic dysfunction. And then you've got alcohol-associated liver disease, specific etiology-associated steatotic liver disease, and then cryptogenic steatotic liver disease. Now, to diagnose mast cell, you need to have one of these 5 criteria. You need to have a BMI that's more than 23 in Indians, or a waist circumference of more than 90 or 80, presence of prediabetes or diabetes, a blood pressure of more than 130 by 85, or the patient should be on antihypertensive therapies, or a triglyceride values of more than 150, or the patient should be on lipid-lowering treatments, or HDL value of less than 40, or the patient should be on lipid-lowering treatments. So you need to have one of this along with presence of some evidence of steatotic liver disease, which qualifies for the term of MASLD. Now, as I said, that it's not really just a liver disease, but there's a host of factors that predisposes a patient to cardiovascular risk. And here's a pathway that sort of leads to cardiovascular disease. We've got hyperinsulinemia, diabetes, atherogenosis, and myocardial dysfunction. And that's what sort of causes a lot of cardiovascular disease rates to be happening. The key question is, how do you really diagnose this in your own clinics? And are really LFTs sufficient, or do we have better markers for risk stratification? These are some of the risk stratifying markers that we've got. We've got, of course, commonly that we see is we do FIB-4 scores in our patients. So that's the simplest thing. All you need is ALT, AST, age, and platelet count, and you can calculate the FIB-4. Very simple to do. Do you need really elastography in all your patients? No. I think if you do the APRI scores, and the APRI scores represent fairly how much of fibrosis the patient will tend to have. So combination of FIB-4 and APRI scores are good enough to assess your patients in the clinic. But for those patients that need a better confirmation, then an elastography can risk-stratify to the degree of fibrosis that the patient has got. So when you look at FIB-4 basal fibrosis score or APRI score, they've got a good negative predictive value for ruling out fibrosis, and these calculators are freely available on the internet. So this is how you calculate FIB-4. All you need is age, AST, ALT, and platelet count, and you can put it in and you can get the FIB-4 score. Elastography is excellent, and it's one of the most reliable in ruling out advanced hepatic fibrosis. And we do that pretty routinely in our patients when we want to risk stratify or stage the patient in terms of what fibrosis he's got. Liver enzymes. So ALT, AST, alkaline phosphatase, and bilirubins are markers of liver injury. You have to remember that. And albumin, bilirubin, and prothrombin are markers of hepatocellular function. Remember that there is no serological test that can distinguish NAFL from NASH or establish a diagnosis of NASH. So it's always a diagnosis of exclusion that we really need to do. Now, based on the FIB-4 score, you can risk stratify, and these are all fibrosis risk stratification that you're really doing. So if you have a FIB-4 of less than 1.3, the patient has got a low risk. If you've got a FIB-4 of more than 2.67, clearly this patient has already got a high risk of fibrosis, and the patient, you can do a ELF score or you can do a liver stiffness median through elastography, and you can determine what stage of fibrosis this patient has got. But clearly, if you have patients with prediabetes or diabetes, obesity with 2 or more cardiometabolic risk factors, or steatosis on imaging, then along with elevated transaminases, then these patients need to be risk-stratified for presence of mast cells. In a very simplistic term, I follow this algorithm. So if you have the risk factor, look at the FIB-4. Is the FIB-4 more than or equal to 1.3? No, then this patient has a low risk of future cirrhosis. They're best managed by their lifestyle intervention programs, managed by the primary care team. If you have a FIB-4 of more than or equal to 1.3, these patients have got a higher risk of cirrhosis. Do the liver stiffness median on elastography. If it is more than 8 kilopascal units, then if it is not there, then clearly this patient needs a better lifestyle management. If the liver stiffness median is more than 8 kilopascals, then this patient needs a hepatologist intervention. Or if the FIB-4 is more than or equal to 2.67, then these patients are better managed by the hepatologist. Now, does FIB-4 really have a prognostic value? And you can clearly see that based on the FIB-4 score, you can have low FIB, intermediate FIB, or a high FIB. And you can see the liver events, cardiovascular events, or all-cause mortality have a clear separation based on the FIB-4 scores. And if you can intervene early, then can you prognosticate the patient with improvement? And here's the evidence that was published very recently in the Lancet, which showed that if you can downgrade the FIB-4 score, the liver events tend to come down. So there is evidence to show that early intervention and downgrading the FIB-4 score will have a translational benefit in terms of reduction of liver events. So I come to the point that we need to screen our patients early, and if you diagnose early, then there is a scope for intervention. And if you intervene early, then perhaps what matters is the pool-specific mortality that you see. So if you see mortality in mast cell is not because of liver problems. And here's the evidence to show in this paper, which was published in the Lancet this year, that if you look at liver-specific mortalities, if you look at extrahepatic cancer-specific and cardiac-specific, clearly the cardiac-specific mortalities tend to be higher as compared to liver-specific events that can cause mortality in patients with mast cell. Now, Can you have a differentiation in mortality in patients who've got MASLD and NAFL along with diabetes? So when patients don't have diabetes, look at the mortality rates when the patients progress from NAFL to NASH to cirrhosis or hepatocellular carcinoma or liver transplant, and compare that to type 2 diabetes. There's absolutely doubling of mortality that happens when the patient has got type 2 diabetes along with MASLD. Do we have treatment options available today? And here's a great algorithm. You don't need too much of really weight loss to have a muscle regression. All you need is about 5% of weight loss, and that will help you to get a muscle regression. So we say that if you do a 5% reduction, you get a steatosis reduction. If you can do 7 to 10%, then you can have a MASH or a fibrosis reduction. And today we've got many drugs which are incretin based or a bariatric surgery that can affect. You've got a lot of diet that is available, and I've just put that over here. So you need to have a dietary intervention. You need to encourage patients to have more physical activity, lifestyle changes, and then, of course, a multidisciplinary care team that monitors your patient very carefully. Don't allow your patients to progress to cirrhosis because you've missed the bus completely. Because it's not just the cirrhosis, but you affect the quality of life and the survival of this patient and the cardiometabolic risk that the patient carries with him. Here are some of the anti-hyperglycemic agents that have been looked for and their effect on the ALT, liver fat, fibrosis, MASH reduction, body weight, and cardiorenal benefits. And clearly you can see here that the GLP-1 receptor agonists or a GLP-GIP or SGLT2 inhibitors, they have benefits across the spectrum in reduction of liver transaminases, liver fat or fibrosis, or a MASH reduction, along with, of course, body weight reduction and cardiorenal benefits. This is the algorithm that has been put out by the ADA in the current standards of care in 2025, where they talk about different stages of MASL and in terms of obesity pharmacotherapy, diabetes pharmacotherapy, and MASH pharmacotherapy. And you can see here that across the board, GLP-1 RAs or a dual agonist, the GLP-GIP, or a pioglitazone tends to have benefits, but more advanced fibrosis, your treatment should be more sort of limited to diabetes pharmacotherapy because that point of time in advanced fibrosis, you don't get too much of benefits by using these agents in terms of regression. This is the recommendations. Can I just take 1 minute more of time? Okay, thank you. So this is the recommendations from India, and this was published very recently by Anup Mishra and others. And very similar, it echoes what the AD has actually mentioned over here. Some of the newer agents in the pipeline, you've got anti-inflammatory agents, metabolic, anti-fibrotic, reduced calorie intake. All these are sort of desired functional changes that you tend to get. But I just point out to you this table where we're looking at obeticholic acid, semaglutide, lanifibranor, resmetirom, and efruximin. Resmetirom has, of course, now got the FDA approval, and hopefully we should have resmetirom available in our country. There's clear evidence in terms of MASH resolution without fibrosis worsening or a fibrosis improvement without MASH worsening to the tune of about 20 to 30% when you use resmetirom for downgrading the stage. But these are usually effective in F2 or F3 stages. Moment the patient is in F4 or advanced liver cirrhosis, these really don't come very handy. You have a number of other agents you can see here which are in pipeline. There are other trial or some of them are going to be available in the years to come, which we hope that we'll have a better way to tools to treat the patient. Never forget that these patients have got a high cardiovascular risk. These patients necessarily need to be evaluated. They need to be on statin therapy. See what the risk conundrum is, whether you need to give aspirin therapy or not, but statins, yes, all these patients should receive statin therapies. Bariatric surgery has shown a clear benefit. No definite benefit whether you look at Roux-en-Y or a sleeve gastrectomy. More or less both have got very similar results in terms of NASH resolution or fibrosis regression. And of course, in terms of liver outcomes or a major cardiovascular outcomes, they have shown clear benefits. I just want to end up by saying that MASL is a highly prevalent condition which is more common in people with type 2 diabetes and is associated with worse outcomes in those with obesity. Reductions in body weight are associated with physiological improvements that improve diabetes, MASL or MASH or cardiovascular risk. Bariatric surgery approved and emerging medications are weight loss dependent and independent mechanisms to improve MASL outcomes. And advocacy is needed to screen for and treat MASL MASH in people with type 2 diabetes. This is evidence-based and patient-centric approaches. We had this publications that we have been part of the group that brought out the guideline statement and a consensus statement for MASL in Indian from an Indian diabetologist perspective. And we wrote this book on MASL. I urge you to read these papers. I think they're excellent to give you some more information. Thank you very much, and thank you for the opportunity.
Thank you. Thank you, sir, for your elaborate talk. Any questions?
Thank you, sir, for the kind words, your wisdom. So just two quick questions. So what is your take on pioglitazone? As we know, it is a true insulin sensitizer, and saroglitazone as well. In terms of NASH, I know it is not yet approved, except resmetirom, no drug is approved. So how you see these two drugs in these conditions?
Okay. So I think the earliest data came from the POEMS trial, which looked at actually vitamin E, and that was a high dose vitamin E that really helped patients in terms of NAFLD, and that was in NAFLD patients they looked at. Pioglitazone has been studied, and Ken Kusi and his associates have really published the data. The earliest guidelines came out of using pioglitazone in terms of liver fat reduction, but the dose that is used is 45 milligrams. So clearly, lower doses, whether it's going to be effective, we don't have that data in the Indian population because we do know that lower doses in Indian populations tends to work, but we know data to show whether 15 milligram or 30 milligram is going to cause. But the 45 milligram, which Ken Kusi published, was biopsy driven, and they could actually show a NAFLD regression with 45 milligram of pioglitazone. What it does is it just sort of translocates the visceral fat to the subcutaneous fat. That's how it causes a fat regression. But it has no effect in terms of fibrosis regression. So that's something that you need to keep in mind. And whatever weight gain you get is a true weight gain. So that doesn't go away even if you stop the drug. In terms of saroglitazone, again, there is very little evidence in terms of fibrosis regression, although the trials are underway whether fibrosis regression can happen. But there is evidence to show that through triglyceride lowering and the VLDL lowering, that liver pathway tends to get affected and they tend to cause a liver fat regression to happen. So it's primarily a triglyceride lowering drug. It has a secondary benefit in terms of liver fat regression, but no clear trials which has shown that fibrosis regression can happen.